Sunday morning. So today's session is psychiatry for neurologists. And in fact, when we were planning this program, we were looking for people who are ideal in giving this talk. And our first speaker today is Srikanth. Actually, Srikanth, I saw Srikanth very accidentally in a meeting in Chennai. You know, there's a saying by Paulo Coelho that when you intensely want something, then nature conspires to give it to you. And that's exactly what happened. And suddenly I found him giving a talk and I found that he's a neurologist, and I found that his great impression is in cognitive disorders, and he has a lot of work done in even psychiatric disorders. And he's, he's very vastly trained. He has done his DM in neurology in Chennai Institute of Neurology. After that, he has done specific dementia training from University of California, USA. He has been trained in neuropsychiatry from St. George Hospital, London. And he has also got further training in these disorders from National Hospital of Neurology and Neurosurgery in London. And presently, he is also in the process of developing instruments, particularly for cognitive disorders, as seen in neurological practice. So I think he's an ideal person who is a neurologist and a psychiatrist, if I will. And Srikanth, the field is all yours. You get about 25 minutes, depression in neurological disorders. Dr. Srikanth.
Good morning. Thank you, Dr. Subhash. Thank you. And this is a topic that is close to my heart. And good morning, Dr. Vijay. And because you're there, and I'm going to speak on depression and neurological disorders from a neurologist point of view. So I'm going to give you a perspective of a neurologist. Okay, which might be slightly different from a perspective of a psychiatrist or a neuropsychiatrist. Okay, so I'm going to start with a brief outline of this presentation. So I'll be briefing you on the clinical features of the depressive syndrome, because we must understand that major depression is a syndrome with multiple manifestations, because it is not just one particular manifestation that makes us diagnose a major depression. It is a syndrome with multifaceted manifestations. And then we go on to deal with the multiple approaches towards diagnosing this major depressive syndrome. And what are the differentials or mimics that a neurologist should keep in mind before diagnosing this major depressive syndrome in neurological practice. And I'll briefly touch upon the subtle differences from primary depression or idiopathic depression that is important that we should keep in mind from a neurological point of view. And then I'll briefly end with some case anecdotes that I would like to mention that are important from the neurological practice. So what is this depressive syndrome that we are talking about? By definition, a syndrome is multifaceted. It has multiple dimensions. So what are the dimensions that make up this major depressive or the depressive syndrome? Because depression can either mean a particular symptom, or it can even refer to the major depressive syndrome. Okay, if it only refers to a particular symptom, then it is not functionally disabling. It might be transient. It can be reaction to certain stressors or illnesses, and it is not very important. It is transient, so it does not have to be taken in a very serious way. Whereas if we are referring to the major depressive syndrome, then it is severely functionally disabling. It has serious consequences. It has to be taken seriously. It has to be treated. So we have to make a clear distinction between depression, which is a mere symptom, and major depressive episode or major depressive syndrome, which has very serious implications for the patient's mental as well as physical health. The major depressive syndrome has at least 5 symptomatic elements. The chief ones are the emotional symptoms and the ideational symptoms. Okay, you also have the cognitive symptoms, the motoric symptoms, and the physical somatic or the vegetative symptoms. You must have seen that I have made the emotional symptoms and the ideational symptoms in bold, because these are the most important things that we as a neurologist or as a neuropsychiatrist have to keep in mind, because many of the times we find that in neurological practice, our diagnosis of the major depressive syndrome is contaminated by overemphasis on the cognitive, motoric, and the physical or vegetative symptoms in a patient who presents to us with these depressive symptoms. If we try to make a diagnosis of major depressive symptom based on cognitive, motoric, and vegetative symptoms, we will almost always be over-diagnosing all these symptoms. We'll be making a lot of false positive diagnosis of depression when patients do not really have major depressive episodes. So it is very important that all our diagnosis of major depression or the depressive syndrome is essentially based on emotional and ideational symptoms. It is anchored on these emotional and ideational symptoms. Of course, they can also have cognitive, motoric, and vegetative symptoms. They might even predominate in a subset of patients, but never make a diagnosis of major depressive symptom based on the isolated presence of motoric or somatic vegetative symptoms, because you're likely to almost always go wrong. Never make a diagnosis of major depressive symptom based merely on the presence of cognitive, motoric, or vegetative symptoms. That's why I've made the emotional symptoms and the ideational symptoms the same. Remember that major depression is a disease of the emotional and the ideational component of the brain. It is not a cognitive, motoric, and vegetative symptoms alone. So that is the point that I want to drill it into all your minds. So what are these emotional symptoms that I'm looking for? The core symptoms that the DSM and the ICD-10 or the 11 DSM-5 and the ICD-11 always emphasize are depressed mood, or dysphoria, and loss of interest or pleasure, which is anhedonia. So there is a very subtle difference that I want to emphasize. This loss of interest is not very important in neuropsychiatric depression. You might have to modify and you have to take the loss of pleasure in neuropsychiatric depression, because loss of interest itself can be an isolated symptom in the absence of depression that you can almost always see in many neurological conditions, because it can be a symptom of apathy that you can see in a lot of neurological conditions. Because this loss of interest or apathy, when you place too much of emphasis on it, can lead to a lot of false positive diagnosis in depression and neurological conditions. So rather than making your diagnosis of major depression based on loss of interest, it is always important to make a distinction and include loss of pleasure as one of the core symptoms of depression and neurological things. That is the emphasis that you will have to place on diagnosis of major depression and neurological things. So keep that in mind, because that's the difference between primary depression as well as depression and neurological conditions. Loss of interest can be a predominant symptom of apathy, and that is, apathy is not depression. So that is one of the important take-home messages in today's talk. Apathy is not depression. Loss of interest is not a core symptom of depression and neurological disorders. So place your emphasis on loss of pleasure or loss of enjoyment. That should be one of the core symptoms of diagnosing major depression. Of course, the other core symptom that ICD-11 places the thing is loss of energy or fatigue. Anergia, that's one of the core symptoms, which is not a part of the DSM criteria, but it's a part of the ICD criteria. Of course, one of the minor criteria are the anxiety and irritability, which is also one of the emotional symptoms of major depression. The ideational symptoms, the depressive cognition, which is also very important to keep in mind, because you have to base your diagnosis of depression on the presence of or absence of these symptoms. These are worthlessness, guilt, hopelessness, helplessness, and suicidal depression, suicidal ideations. So these, in essence, the concepts of self-deprecation or low self-attitude. Those are very important, because depression basically is a disease of the mind. Okay, it's not a cognitive or a motoric or a physical or a neurovegetative condition. So in addition to the core symptom of depression, you also have to elicit for these ideational symptoms. If you base your diagnosis of major depression on the emotional as well as the presence of ideational symptoms, you're likely to minimize your false positive diagnosis of depression. So that is why always elicit for worthlessness, guilt, hopelessness, helplessness, in the presence of suicidal ideation. Very sensitive and empathetic questioning can almost always elicit for all these symptoms. If you base your questioning on self-deprecation, low self-attitude, anhedonia, as well as dysphoria, so you almost always 80 to 90% of the time, you can elicit a very good percentage of the presence of major depression, even in neurological patients, even in the presence of mild to moderate cognitive impairment. So that is why you will have to develop your skills for diagnosing major depression. Of course, the cognitive symptoms of depression are reduced concentration, indecisiveness, and forgetfulness. The kind of forgetfulness that you get in major depression is not one of loss of recently acquired information, but it is one of difficulty in getting the information into the memory stores in the first place, because the patient is not able to pay enough attention to get that memory into the brain in the first place. So, for example, he will tell you that, doctor, when I open the fridge, I'm not able to remember why I opened it in the first place. When I get into a room, I just forget why I went into the room in the first place. So even in the history, you'll be able to find out what is the difference in the kind of forgetfulness that happens in depression-associated memory disturbances, whereas the memory forgetfulness that you get in neurodegenerative conditions like Alzheimer's disease and vascular dementias and those other kinds of things. So even very sensitive questioning about the type of memory disturbances can tell you whether it is due to depression or whether it is due to incipient neurodegenerative conditions or dementias. So even those kinds of history, simple questions in the history can tell you what is the kind of forgetfulness that happens in depression versus neurodegenerative conditions. So these are the cognitive accompaniments of depression. Motoric symptoms, as we all know, can either be psychomotor retardation or agitation, hypomimia, low voice, reduced facial expression, and slowness of speech and movement. And of course, leaden paralysis, which itself is a component of atypical depression. This can give you an appearance, the patient looks Parkinsonian when actually he is not Parkinsonian, because he does not have the classical accompaniments like tremor, rigidity, bradykinesia, and all those things. So the somatic vegetative symptoms, of course, are reduced appetite, which is more commonly seen, and increased appetite, which is a part of atypical depression. Insomnia, which is more common, versus hypersomnia, which is a part of atypical depression. Fatigue or loss of energy. I've made it bold because that is one of the core symptoms of the ICD criteria, and of course, reduced libido. So these are the major symptoms of this thing. These might not be captured in all the major screening scales that we have currently in use. So on asking for all these specific questions would not take more than 7 to 8 minutes, even in a busy neurological practice. So it takes not more than 7 to 8 minutes to ask for all these questions. So even though we have a lot of scales to use that we can apply in clinical practice and research settings to diagnose dementia, it does not really matter what is the particular type of scale that you use. What matters is to be sensitive to the presence of depression, to be aware that depression might be present, and to use sensitive and empathetic questioning to elicit the symptoms of depression, and be aware that depression screening does not take a lot of time. So there are specific screens that have been developed to diagnose depression even in neurological settings. Of course, in epilepsy, you have the neurological disorders depression inventory for epilepsy. You have the interictal dysphoric disorder inventory to diagnose depression. In stroke, you have the post-stroke depression scale and the stroke aphasic depression questionnaire to diagnose people who have aphasia. You have difficulties in voicing their symptoms of depression, which is more an observational scale. In dementia, you have the Cornell scale for depression, and dementia, you have the dementia mood assessment scale. So one of the particular important aspects of diagnosing depression and dementia is that in dementia, not only do you elicit symptoms of depression for the patient, but you also get input from a primary caregiver or a chief informant, and you also reconcile the differences by your own observations of the patient. So this is the important aspect in diagnosing depression and dementia. You do not need any specific scales. You do not have to address any specific questions which are uniquely pertinent to diagnosing depression and dementia. You just have to address the same questions to the patient as well as the primary caregiver, make your own observations, and then reconcile all these differences to arrive at a particular conclusion to find out whether the particular patient with dementia is depressed or not. That is what it needs to take to diagnose depression and dementia. You do not phrase or paraphrase a question in a particular different way. So these are the skills that you need to diagnose depression and dementia. There are nothing unique to diagnose depression and dementia. But you must understand that all these specific scales are not at all needed. You can use a simple scale that is validated even in non-neurological populations. Use it in a very sensitive way. Get trained in using it in a large number of patients, and you can use it so that you can diagnose this thing. So you learn to use one particular scale, gain valuable experience, and you can become an expert in diagnosing depression and dementia. Even GPs can do it, so why can't we do it? And after all, depression is the second commonest chronic medical condition that we see in medical practice. So next to hypertension. So I think, and most of the depressions are treated outside of routine psychiatric settings. So I think mild to moderate depression, every medical practitioner should be aware of treating it. Leave the more severe and refractory depressions to the specialist psychiatrists. So I think all of us should be trained in diagnosing and treating mild to moderate depressions. So in addition to diagnosing depression, once you decide to diagnose, recognize, and treat depressions, it is also important that you must learn to recognize the comorbidities. The commonest comorbidities are these: anxiety. 40 to 50% of every depressed patient is also going to have anxiety. So learn to recognize anxiety. About 10 to 20% of every depressed patient is also going to have psychotic manifestations. So learn to recognize psychosis. Include one question each for anxiety, psychosis. Of course, a small minority is going to have bipolar depression, okay, as part of bipolar disorder. So include one question for mania to recognize bipolar disorder, because your management strategies are completely going to be different. And you also have to recognize alcohol and substance misuse, which is very important. So include one question each for anxiety, psychosis, mania, and alcohol and substance misuse. These are very important for management considerations. So briefly touching upon your approach to diagnosing depressive disorders and neurological disturbances, you must have a low index of suspicion. That is the single most important attribute that you must have as a neurologist. Use the inclusive approach, okay? That means that don't diagnose depression. Don't ask, are you able to sleep properly? Are you able to eat properly? Not being able to sleep properly, not being able to eat properly merely does not make a diagnosis of depression, okay? Those can be part of neurological conditions. Patients with dementia, patients with multiple sclerosis, patients with stroke will also not be able to sleep and eat properly. The mere presence of insomnia and low appetite does not diagnose depression. In addition to all this, patients must also have the emotional or mood symptoms. Patients must also have the ideational symptoms. Those are the most important or the core symptoms of depression. So use an inclusive approach and focus on all the facets of the major depressive syndrome. Use a 2-question screen because it saves time. Ask for the core symptoms, ask for dysphoria, ask for anhedonia. If those are negative or those are positive, then go on. Those are positive, then go on to the longer screen. So I would suggest the most valuable test is the PHQ, the Patient Health Questionnaire. Use the PHQ 2 and then go on to the PHQ 9, because that's exactly based on the DSM-5 criteria. And it also gives you an idea of the severity of the depression, so that repeated administration and subsequent visits can give you a severity of this thing. And do not diagnose this by mere depression. Looks depressed. Every Parkinson patient is going to look depressed. So it does not make everybody depressed. Mere tearfulness, the loss of sleep, of appetite, fatigue is not depression. Always get input from a knowledgeable informant. So what are the neurological mimics of depression? The commonest ones are hyperactive delirium, dementia, medial frontal lobe or subcortical lesions, and the adverse effects of medications. Of course, the first 3 conditions also affect alertness and cognition. So do a careful clinical exam, including cognitive testing and a basic neurological exam, and that can be usually revealing. So what are the specific neurological drugs causing depression? Sedative hypnotics, especially benzodiazepines. So the non-benzodiazepine sedative hypnotic, like the Z drugs, zolpidem, zopiclone, and zaleplon, do not cause depression. Anti-Parkinsonian drugs like amantadine, bromocriptine, cause depression. Very rarely, levodopa also can cause depression. Phenobarbital, primidone, vigabatrin, topiramate, zonisamate, tiagabine are the anticonvulsants that have been associated with depression. Remember that all of these are GABAergic anticonvulsants. Donepezil has very rarely been known to cause cholesterol inhibitors. Anti-migrainous prophylactics like flunarizine and beta blockers can cause depression. And miscellaneous drugs that are used in neurological practice like corticosteroids, baclofen, acetazolamide, and azathioprine can also cause depression. So it's worthwhile keeping all this in mind. The most important distinction that we have to make in neurological practice is distinguishing apathy from depression. So apathy is a generalized state of disinterest. Physical disinterest, cognitive disinterest, as emotional disinterest. So the patient has reduced experience of both positive and negative emotions. He also has a reduced expression of positive and negative emotions, and he expresses a lack of concern about all these symptoms. Whereas in depression, he feels sad, he feels guilty, he feels hopeless, he has a negative cognitive bias, everything is negative, and he feels an emotional emptiness. But he is not unconcerned about all this. He feels agitated. Okay, that is the difference between apathy and depression. The depressed patient also feels negative emotions, but he is not at all unconcerned about it. He is distressed about it. That is the difference between apathy and depression. So it's worthwhile keeping this in mind that apathy is not depression. Mere lack of interest is not depression. Apathy is lack of interest and unconcerned about this lack of interest, whereas depression is lack of interest and feeling disinterest about this lack of interest with a negative cognitive bias. So what are the recommended scales to diagnose depression? Simplest ones are the patient health questionnaire, 2, followed by application of the patient health questionnaire if the 2-question screen is positive. You can also use the geriatric depression scale 15, the short form of the geriatric depression scale, even though I feel some of the questions of the GDS 15 are not suitable to our population, and it's more suited to the Western populations. Of course, the gold standard, of course, is the clinician administered Hamilton Depression Rating Scale 17. The Montgomery-Åsberg, the depression rating scale is also very good. Why I've recommended these scales is because the Indian language versions are freely available, and these are also validated in patients with cognitive impairment. So even in Parkinson patients, dementia patients, stroke patients with mild to moderate cognitive impairment, these are valid. So how does depression in neurological patients differ from primary depression? These are very, very subtle differences. Okay, so let us not make a song and dance about it, even though in research settings and academic settings, these are very important. Phenomenologically, there are only subtle or minor differences. But neurobiologically and therapeutically, there are very minor differences. These are not at all therapeutically very, very relevant at present. So we'll just go through quickly what are the minor differences. In Parkinson's disease, there is an excess of anxiety, and there are greater motor fluctuations and more cognitive impairment in depressed Parkinson patients. There's more functional impairment. It's more common in the akinetic rigid variant. In epilepsy, these depressive episodes are much briefer, associated with excess irritability and dysphoria. In stroke, depressed patients exhibit more bizarre somatic symptoms with much more delusional features. Delusions about somatic symptoms, somatic delusions. In multiple sclerosis, there is more irritability, more frustration, and high frequency of suicide. As indeed we see in Huntington's disease, where there's an unexplained higher rates of suicide in Huntington's patients. Of course, in dementia, depression is much more common in vascular than Alzheimer's dementias. Major depressive episodes are much, much rarer. For example, in my series of more than 1,000 patients with dementia over the past 15 years, I've hardly seen 5% of patients exhibiting major depressive episodes. There is much more irritability and a much higher rate of functional deficits. So what it means that depression in dementia is much more related to functional impairment rather than to the actual level of cognitive impairment. But these are minor differences which are not very therapeutically relevant. So what are the therapeutic pearls that I would say? So I think we all can treat mild to moderate relevant and depression, and if you have the expertise, you can also treat more severe depressions. Be familiar with one or two drugs from each class. Be familiar with both sedating and less non-sedating drugs. Be aware of the titrating schedule, and know when to recognize treatment refractoriness and when to refer to the specialist for further management. And drugs are not the only options. Know about psychotherapy, ECT, transcranial magnetic stimulation, and transcranial direct current stimulation. These are also very, very effective, which can also be used in patients with neurological disorders. My favorites are, among the TCAs tricyclics, I use dosulapin and nortriptyline. Dosulapin, which is a derivative of amitriptyline, much less sedating, much less anticholinergic. Nortriptyline is less sedating, can be used as even in refractory depression. Among the SSRIs, sertraline and escitalopram are my favorites. Sertraline is much more activating, can be used in very sedative patients. And escitalopram, of course, is the eternal favorite, used for painful conditions like diabetic neuropathy, fibromyalgia, and chronic low back pain. Among the monoamine oxidase inhibitors, selagelin, because neurologists are much more familiar with this, having used it in Parkinson's disease. Among the atypicals, trazodone and mirtazapine, because trazodone and mirtazapine are much more sedating and have very less sexual side effects. So these are my favorites. So be familiar with most of these newer and older generation antidepressants, and we can use it as well as any general psychiatrist, because some of these are also used in neurological practice to relieve pain and other things. So briefly touching on a couple of case anecdotes. The first patient is one of a 30-year-old girl with chronic epileptic, and for 8 years, not getting controlled with medication, and then saw her for the first time 3 years ago. Had very good drug compliance, and then EEG unremarkable, MRI showed mild left epicampal sclerosis. When he saw her first, she was on oxcarbazepine and clobazam. She was tearful and withdrawn, was not very cooperative for depression assessment, so I deferred the depression assessment for the next review, and then asked the father to give me a telephonic call later to collect more history. The father told me that the family was worried that she was not, they were unable to get her married because of the continuing seizures. And she was working, but the office colleagues, the manager was not very happy with the work because she was continuing to get seizures. She was forgetful and less attentive, and she was a little lethargic. And she was also having unsupportive sister at home. So at the next visit, I was able to do her depression assessment. She got 20 out of 27.
Sir, good morning.
Yeah.
Sir.
Yeah. So I was able to increase the thing.
Next time उसके घर जाएंगे जब तू यहाँ आएगा तो. You like our house very much.
I was able to increase the oxcarbazepine and tail off the clobazam. Seizures stopped, and then I started on sertraline and gradually increased to 100 milligrams per day, and subsequently seizures completely stopped, and she became completely all right. So this goes on to show that it was a seizure, it was a depression which was worsening a seizure.
We make webinar attend.
Once we stop the seizures, depression and seizures were completely getting better. So that was what was the take-home message from this thing. So it's also important to manage the neuropsychiatric complication to make the neurological condition also get better. The second case was a 59-year-old man diagnosed with Parkinson's disease 1 year ago. Had a persistent complaint of severe low back pain radiated to the left lower limb with occasional cramping, but was not related to the off period. So it was not a Parkinson-related pain. Motor symptoms well controlled with dopa agonist and levodopa. Recently retired, increasingly becoming less communicative, spending long hours on the internet reading about Parkinson's disease and all its complications. Neurologically, no evidence for radiculopathy. Treated with diclofenac 150 mg per day for 3 weeks, no relief. Next visit, obtained an MRI of the lumbocervical spine, which was normal. And then I smelt depression. Did a PHQ-9, scored 13 out of 27. So started on duloxetine 13 mg per day. Was completely pain-free in a month's time. So have a low threshold for suspecting depression, and then start them on the appropriate drug, because I started on duloxetine because it was a painful manifestation of depression. So to call it a masked depression, so rather masked depression, and he became completely free. So be aware of masked presentations of depression even in neurological patients. The third case, of course, is a classic scenario. A 70-year-old elderly gentleman, highly educated in a very high-ranking corporate job. He was the director of a very big, large corporate organization. Forget interest in severe irritability. And bedside cognitive testing, 5-word list recall was normal. Verbal fluency was reduced, 9 animals per minute. For his age and educational achievement, I expected at least 12 to 14 words. On depression screening, he endorsed dysphoria, severe anhedonia, depressive cognitions, had hypersomnia and increased appetite, more towards the atypical spectrum. He had prominent anxiety and irritability with agitation. And depression with mild cognitive impairment was the diagnosis I made. MRI scan was obtained, which showed normal hippocampi. He was started on duloxetine 13 mg per day, 30 mg per day. Remember that the drug of choice for depression-associated cognitive impairment, one is duloxetine, the other one is vortioxetine. These are the two drugs that should be used for depression-associated cognitive impairment. And I also started him on modafinil 100 mg morning and noon. And within a month's time, he reported 75% resolution of all his symptoms. And his irritability, his dysphoria, his increased appetite, hypersomnia, everything had resolved. So this is a classic case of depression-associated cognitive impairment. Earlier used to be called the pseudo-dementia. So in neurological practice, not only do we see pseudo-dementia, but we also see pseudo-depression. What happens is, a lot of neurological disorders also result in pseudo-depression. The neurological disorders give the superficial appearance of depression because the patient appears lethargic, there is hypomania, there is leaden paralysis, the patient has relative bradykinesia. So all these give the appearance that the patient might be superficially depressed. This is called pseudo-depression. So not only should we be aware of pseudo-dementia, we must also be aware of pseudo-depression. So both these conditions, opposite conditions, can also happen. So this is why there is a very strong link between depression and neurological disorders. There is a two-way, bidirectional link. So we must all be aware of it, because if we treat these neurological disorders, the general prevalence, point prevalence of depression in the general population is about 6 to 10%, whereas in neurological disorders, it goes to about 20 to 30%. So there is a very strong link between depression and neurological disorders. Treating this not only improves the neurological condition per se, but it also improves the general condition of the patient and has a very good functional improvement, so that the patient's quality of life is improved. So recognizing and treating depression is a simple process. It is a rewarding process. So I think as a neurologist, it's such an easy process, and all of us should be aware of it. And it's easy and rewarding for all of us to undertake this process. Of course, mild to moderate depression, every one of us can be is within the realms of all of us to manage it. So of course, the severe refractory depressions can be referred to the specialist psychiatrist. So just like severe diabetes and hypertension can be treated by neurologists, and we don't refer it to the endocrinologist, mild to moderate depressions can be treated by all neurologists. And I think we should all endeavor to be aware of all this mild to moderate depression, so that the quality of life of our patient and the improvement in neurological condition that we all aim for in our patients can be easily accomplished. Thank you.
Srikanth, thank you very much. I think it was, you can stop sharing your screen.
Thank you.
I think it was extremely useful. Some of the points which you made were very, very timely and important, like having a low threshold for suspecting depression. Also the concept of pseudo depression. It may not even be depression, it may be pseudo depression. And you gave us the clues, and also differentiated from apathy. And also you gave a flavor of depression in different diseases, depression in Parkinsonian compared to depression in stroke, compared to depression in multiple sclerosis. I think and also the best thing you said is that you may not need the entire neuropsychiatry, you may need few drugs, but be well aware of those. I think neurology and psychiatry basically is one branch only. It is neurology and psychiatry. As in US, many degrees are neurology, diplomate of neurology and psychiatry, but we have artificially divided it. Thank you so much. And I think for the sake of attendees, these talks are also going to be on the FINE website and also on eventually on YouTube, and you can benefit from them. Srikanth, I would request you to stay for next 20 minutes or so, because we have a psychiatrist talking to us, and after that we'll have a combined question and answer session if the time permits. Thank you very much. Now, dear friends, Srikanth is a neurologist and with a training in psychiatry and cognition, so he's very lucky. Most of us are not that lucky. We are trained only in neurology, and our exposure to psychiatry is very limited. So therefore, from time to time, we need the help of a psychiatrist. We use escitalopram, not more than 10 milligrams. And after that, we get shaky and want to send it to a psychiatrist. We are very skeptical in using phenothiazines, even the new ones also, and we're always afraid about side effects. So therefore, I thought it's very appropriate that we should have a lecture by a psychiatrist who will tell us how much of psychiatry a neurologist should need, particularly for drugs. So it's my pleasure to introduce, in fact, my colleague, Dr. Vijay Seshadri, who works in KIMS Hospital, Secunderabad, but that's his part-time engagement. He's a clinical director of Chetna Hospital, which is a 40-bedded psychiatry hospital where they admit patients. He is trained in psychiatry from Manipal Hospital, and I think he would be the most appropriate person to talk on pharmacotherapy of psychiatric drugs for neurologists. So, ladies and gentlemen, please welcome Dr. Vijay Seshadri. Vijay, you can start sharing your screen. Yeah, Mansi, can you help? Thank you, Srikanth.
Thank you. I think the other screen sharing will have to stop for me to turn it on.
Yeah. Srikanth, please stop sharing.
Dr. Seshadri, you will have to click on the green share screen. Yeah.
Yeah, I think is it okay? Is this
yes, on? We can see it now.
Yes, you will have to move it to the full screen. Yes, perfect.
All right. Good morning, and thank you, Dr. Subhash Kaul, for asking me to talk on this topic. So what we spoke initially was a 20-minute talk looking at some practical psychopharmacology for a neurologist in his or her outpatient clinic or in the hospital. What I want to do is to give a brief overview of some clinical practical aspects of managing some common medications. I thought I'll use a few clinical case scenarios and take a call on what are the treatment options. It is not possible to cover all the conditions or all the medications in a 20-minute presentation. And I don't want to go ahead and discuss too much other finer pharmacological details about this. So I'm going to try and keep it more clinically pertinent. What I hope to address is what are we trying to treat? So as a neurologist, when we are looking at behavioral syndromes, what are we treating? It's good to define the problem. When do we want to treat? So is there a need for pharmacological treatment? How do we go about with treatment? What if treatment does not work? How long to treat and when not to treat? So a lot of times when we see people asking us about psychotropic medications, I actually tell them that more psychotropics are written in the neurology outpatient department than sometimes in the psychiatry outpatient department, because a lot of presentation of psychological and behavioral syndromes take place in the neurologist OP. Partly a lot has also got to do with the stigma of coming and seeing a psychiatrist. So I'm going to start with Miss C, and this is a common clinical case scenario. This is a 23-year-old female, had a breakup in the relationship. She's been preoccupied with the thoughts of that person. She feels depressed. She's not been able to sleep. She's sometimes tearful. She also says that she was depressed for a few weeks after her grandmother died the preceding year, and she was treated for it. Now, is this lady depressed? Answer is yes. Is she upset? The answer is yes. Does she need antidepressants? So one of the commonest types of the so-called depression, if I may use, is the reactive emotional state or the adjustment disorders with which people present to either a primary care physician or to the hospital outpatient department. The preoccupation is typically reflective of the stress, and it generally resolves with time as the stress resolves or coping mechanisms improve. This lady said that she was treated last year after, the preceding year after her grandmother died. Grandmother's death would have probably evoked a grief reaction, which is a normal reactive emotional state. So we don't really need to treat this subgroup of population with antidepressants medications. Sometimes a short course of benzodiazepines might aid sleep-related disturbances or if there is significant anxiety. Antidepressants commonly not needed in this subcategory. However, if it is persistent, it is prolonged, if it is significantly affecting the activities of daily living, or there is an imminent risk of self-harm that is evolving, you might want to consider the role of antidepressants. You probably would look at more of psychotherapy if necessary at all in this population. We'll move on to the next gentleman. He's a 37-year-old male, started with loss of sleep and appetite, had significant weight loss, later developed fatigue, disinterest in activities, low mood. He felt hopeless and worthless. He thought he was a burden on family. This is a typical patient who would come with multiple medical evaluations at multiple hospitals. Nothing significantly came up. Now, this is the person where we would think, is this a depressive episode that we are treating? And it's important to assess whether what is the severity of the depressive episode. Is it mild? Is it moderate? Or is it something which is more severe? Is it a psychotic depression? Is there a risk of self-harm that this individual carries? As the previous speaker was saying, does he need specialized inpatient care? Does he need a referral? Or can I go ahead and consider antidepressants? Now, one of the big challenges that comes in even before starting antidepressants is sometimes when patients come in, we say all the reports are normal. There is no problem at all. Then in the mind of the patient is, if everything is normal, why am I feeling this way? And why is my doctor giving medications? I think it's absolutely important that besides being pharmacological prescribers, we need to be able to talk to people and explain as to how depression itself being a medical condition, though there may not be enough lab evidence to support this particular diagnosis, at least at this point of time, nevertheless, it is a medical condition. When you want to look at antidepressants, pretty much almost all antidepressants are equally efficacious. They take about 2 to 4 weeks for optimal response. The need for an adequate trial is very important. If you see a lot of times people come to us already with having multiple records, 5 antidepressants were tried, 4 different drugs were tried, but none of the drugs were given either at an optimal dose or at an optimal duration. So it's important that when you're starting any drug, and you have the right to choose what drug you are comfortable with starting, but you need to give it at an optimal dose and give it for at least a 4 to 6 weeks trial. You may want to add benzodiazepines initially because since most antidepressants take a few weeks to start working, the benzos will immediately work in helping in cutting down the anxiety and also improving with the sleep, which itself starts helping the individuals. Now, when you are looking at choosing antidepressants, you may want to look at what is the clinical profile of the patient while choosing an antidepressant. Is this a person who is obese? Is this a person who is very thin? Is this a person who already has obstructive sleep apnea? Is this person already having other pain syndromes, chronic pain syndromes? So based on that clinical profile, it might further aid in deciding on what antidepressant might be a good option to look at. past good response to a particular antidepressant is a good predictor for further response in a new episode. So if I have a patient who responded well to an antidepressant A, B, or C 4 years back or 3 years back, and he or she has a relapse of depression, then I could probably go back to the same drug. I think it's also important for us not to just prescribe, but also discuss the duration of treatment besides discussing the diagnosis of depression itself. It is also important to discuss possible side effect. And very often what we tend to see is patient has started off with drug A at a particular doctor. Within 17 days or 14 days, he's not all right. So drug B is added, and then he's not better. So drug C gets added. So polypharmacy with antidepressants does not necessarily help, but it probably ends up doing a little bit more damage. So I think this is just some important considerations to keep in the back of the mind when you're looking at using an antidepressant. What do I start? So I'm going to talk basically from what we do in routine clinical practice. What do we practically do rather than looking at covering the entire gamut of antidepressants? So SSRIs over a period of time have become the mainstay of antidepressant treatment. Escitalopram has probably become one of the most commonest antidepressants to be prescribed. Sometimes we wonder whether people have an escitalopram deficiency syndrome because they get prescribed so much of escitalopram in a general hospital setting across various specialties, whatever be the indication, whether it's depression or something else. So ideally, you want to look at an antidepressant dose of about 5 to 20 milligrams. You probably start at 5 milligrams, wait for a couple of days, go to 10 milligrams, wait for at least about 10 to 15 days, go up to 20, wait for about 4 weeks. If you think that there is a partial or a moderate response to escitalopram, then go up to 30 milligrams. If you think that there's a reasonably good response with residual symptoms, then you can go up to 40 milligrams a day. Similarly with sertraline also, start with 25 to 50 milligrams a day, wait for about 2 weeks, go up to 100 milligrams. That's a good antidepressant dose. But if your patient is a partial responder, has a moderate response at least to 100 milligrams, then there's no need to add another drug. You can go ahead and optimize the dose to 150 and then go to 200 milligrams thereafter. Similarly with fluoxetine. So these are probably some of the commonest SSRIs that we are currently using for treating depression. Not to mention that there are not other SSRIs, but I thought we look at what we commonly tend to use. The other class of drugs that have become increasingly popular over the last couple of years has been the SNRIs with venlafaxine and then subsequently the desvenlafaxine, which has probably come in. Start with 50 milligrams a day. After about 2 weeks, go up to 100 milligrams. Wait and watch and see. Again, if people show a moderate response and they are tolerating the drug well, there is a scope for optimizing the dose a little further to maybe 150 to 200. But don't start at an optimal dose right at the start. I thought because I was addressing neurologists, I thought looking at duloxetine, I highlighted is because I think duloxetine seems to help a reasonable number of people who also have chronic pain syndrome, and a lot of your practice is people with pain syndrome, cervical pains, neuropathic pains. However, I tend to see generally is that, and also what Professor Subhash Kaul was saying in terms of probably giving a little lower dose, we also tend to see people are usually on about 20 milligrams or 40 milligrams of duloxetine a day. And probably some of them do respond. And when they don't respond, then we think of probably changing over the medication or looking at a referral. But actually, if you think that your patient might benefit by getting duloxetine, and if he's on 30 milligrams a day, optimize it to 60 milligrams a day, wait for 2 weeks, see the response, go to 80, tolerating the drug well, still symptomatic, you can go up to 120 milligrams per day. So there is a scope for giving more optimal doses, which is likely to optimize the recovery rather than probably having to just change the class of drug by itself. There are other medications that are there. Mirtazapine was also something that the previous speaker spoke about. Mirtazapine has a good sedative effect. So, and mirtazapine also increases the appetite significantly. So if I have somebody who's losing a lot of appetite, who's losing a lot of weight, then I would probably want to consider mirtazapine also for its side effect of causing increase in appetite and increase in weight. But to the contrary, if I have somebody with 104 kgs with poorly controlled diabetes and also has an OSA, then mirtazapine might not be the choice of drug that I would want to look at. TCAs, the usage as antidepressants, again, if you look back at what I initially mentioned, the efficacy wise, any class of antidepressant is probably as good as any other class of antidepressant. TCAs, we have been using them lesser as a primary psychiatrist. Probably if they don't respond to one SSRI or another class of drug, then we would probably still go in with dothapin or doselpin. We probably go with 75 milligrams per day and then gradually optimize it to 150 and go to 225. As a class of drugs with the TCA, we need to be watchful about anticholinergic side effects. Again, we tend to see people who probably respond to some somatic symptoms, maybe some neuropathic pains at lower doses of medication. But then when you are treating a significant clinical depressive episode or a major depressive disorder, then probably more optimal doses are necessary to treat the episode of depression. And just a brief mention of some of the newer drugs that have come in. Again, vortioxetine was talked about the earlier speaker, and vilazodone, probably a little better sexual side effect profile. Vortioxetine is more expensive as compared to many other antidepressants. It's been out, I think, in the last 6 months to 1 year in India. Vilazodone has been around for a while, starting at about 10 milligrams per day, go up to 20 in about 2 weeks, and then you can optimize it to up to 40 milligrams per day. So what do I commonly watch out for when I prescribe antidepressants? So common things to look at is GI intolerability. I mean, that's probably one of the commonest things that we tend to see. When you start SSRIs and SNRI, you can probably see an initial increase in anxiety. So the patient calls you back in 2 days and 3 days and says, I'm actually kind of worsening. They can sometimes experience tremors, which could possibly be drug related, or it could also be anxiety related. We often see fluoxetine prescriptions being given at night. The antidepressant is good, but one of the commonest side effects of fluoxetine is to cause insomnia. So when you give it at the night, then it actually worsens the insomnia further. And to the contrary, sometimes people may also complain of hypersomnia, especially drugs like mirtazapine sometimes can have a little bit of an unpredictable sedative response. And there are patients who might end up complaining that I've been sleeping way too much and just I'm not able to get up. Restless leg syndrome is something that I tend to see a fair bit with some of my patients on antidepressants, especially with mirtazapine and sometimes with also with SSRIs. I think RLS, restless legs, doesn't get picked up very often, even amongst many of our colleagues, because in the background of depression, patient is already saying, I'm feeling restless all the time. And then he complains of excruciating leg pains, not being able to sleep. And often it is subsumed as being a part of the depression, wherein, in fact, it is probably a part of the primary a drug-related effect. Anticholinergic side effects, as I mentioned, you may want to keep a track on whether there is a low weight or an low or an increased appetite and impact on weight. So when there is other comorbidities that are taking place, you might want to factor in this also when you decide. Sexual side effects is sometimes a worry. Sometimes I feel that the sexual side effects discussion comes in more in people who have read about the antidepressants and come back. Sometimes the primary depression itself can cause low libido, can cause erectile dysfunction. But then also we understand that SSRIs can contribute towards sexual side effects, both in male and female. And I think we need to be cognizant about it and inquire about it. And then I've left the rare side effects, which we don't see very commonly. Very rarely we probably come across hyponatremia, serotonin syndrome. These are very rare. Of course, in neurology practice, because SSRIs, especially on more optimal doses, may be a little seizurogenic. So we probably need to watch that out as well. So what do I start? Basically, any antidepressant class is okay, which is fine. But you might want to keep a track on what has been the past response. You might want to keep a track on whether this person has sexual issues. As I mentioned, some of the comorbidities. Another thing to factor in is, especially if patients are coming in alone, and is this patient at a risk of self-harm? Because many of our patients who develop depression actually overdose on the medications that are prescribed by us. So if I'm going to give a tricyclic to a patient who is moderate to severely depressed without supervision, then I might have a higher risk, whereas an SSRIs might have a broader therapeutic window. So I would probably want to factor in that. What happens if it does not work? I think you should relook at the diagnosis. Is it depression actually that we are treating? Are there other comorbidities and significant stress that's taking place? Have we given an adequate trial, at least 4 to 5 weeks of an antidepressant at optimal doses? So for example, if I had started escitalopram at about 5 to 10 milligrams per day, I've gone to 20 milligrams in about 2 weeks time, then I have to wait subsequently for another 4 weeks before deciding that the drug is ineffective. You might want to think of changing it to a different antidepressant class. So I have somebody on an SSRI who complains of severe GI intolerability or complains of significant weight loss. I might want to think of a tricyclic or mirtazapine. You might sometimes want to think whether combination of antidepressants is good. So generally, while at the start of treatment, a combination of antidepressants is not recommended. However, if you have somebody who's responded well to a particular drug, but also is needing a sedative medication and is probably at a high risk of developing benzodiazepine dependence, then you might want to consider an SSRI with trazodone or mirtazapine. Trazodone and mirtazapine primarily not as much as an antidepressant, but probably using for chronic sleep related issues. First episode depression, remember you need to treat for at least 6 to 9 months. After the episode has resolved, and if there are 3 or more episodes, then you need to look at long-term maintenance medication. If you've had 2 episodes, it's a little bit tricky. You have to think whether if they were mild to moderate, then you give another 6 to 9 months and taper off and see. But if there were 2 severe episodes and the inter-episode duration was very less, then you might want to still think of long-term maintenance after a second episode. Always taper the dose over a couple of months and discuss the possibility of relapse with the patient. And also it's important to talk about the role of maintenance medication. Now the same gentleman that we treated comes back after 7 weeks. He buys you a very expensive gift. He tells everybody, I'm extremely happy. This is the best doctor I've ever seen. This is the best phase of my life. He says, I've become turbocharged. The spouse now comes in and says she can't keep pace with his activities. He's talking too much and he's overactive. So one needs to be aware that it's not just prescribing antidepressants, but one should be able to keep track of the possible change in an affective state. And there is a possibility that though the presentation happened with depression, there could be a possible underlying bipolar disorder. So it's also important when you start antidepressants to inquire if there were previous episodes of hypomania or mania, or if there is a family history of bipolar disorder. One will definitely need to stop the antidepressant, involve a family or a caregiver, discuss the concept of bipolar mood disorder. You may still have to treat because the patient might be getting a little disruptive or might be going through a high where a lot of impulsive behaviors. You may want to add benzodiazepines and probably some antipsychotic, olanzapine, risperidone, and you probably want to consider a referral to a specialist psychiatrist in such a case scenario. I'll now go on to the second case. This is Mr. B. He's a 17-year-old person who presented with chest pain and palpitations, later developed shortness of breath and tremors. He had multiple emergency room visits. Someone in the neighborhood had developed COVID. He has reviewed COVID extensively with all available literature on the internet. So this person could actually be presenting with panic attacks. So you are probably looking at a recurrent episodic anxiety. You might also see there could be free-floating anxiety that might be taking place between these episodes of intense panic. These attacks could be situation specific, and there could be a lot of avoidance behaviors. And then after treatment, his episodes of panic are much better, but parents are now worried about his repetitive behavior. And they say he used to wash so much even before COVID, and now it is too much. And this is a presentation that we've been seeing at least in the last 1.5 to 2 months, an exacerbation of certain preoccupation with cleanliness and contamination. They also say he keeps spraying excessively and walks in an odd manner. So when you are looking at somebody with an anxiety disorder, you also additionally want to consider whether it's a panic, it's generalized anxiety, is he developing OCD, is it hypochondriasis, or also a substance abuse disorder, because substance abuse disorder can mimic anxiety related disorders. And what is the primary pharmacological management? I think there is an overwhelming support towards SSRIs as now primarily being the mainstay of treatment. Since the talk is essentially on pharmacological overview, I'm not going to discuss about other management options, but SSRIs, SNRIs, and probably clomipramine, especially in OCD. When I look back at the same class of drugs, which I had kind of brought it up when we were talking about depression, when you look at treatment of anxiety disorders, you might want to look at similar doses as you treat a major depressive disorder, as you treat a depressive episode. But when you come to obsessive compulsive disorder, then most of these SSRIs have to be given at a more optimal dose. So the anti-obsessive dose of SSRI is much more than the antidepressant dose of SSRI. So escitalopram, you might have to go up to 40 milligrams, sertraline 200 milligrams per day, and very rarely we also go up to 300 if they have moderate response. Fluoxetine usually 60 to 80 milligrams per day, paroxetine and fluoxamine. Venlafaxine and desvenlafaxine are two SNRIs that we commonly use, and clomipramine amongst the TCAs, especially for people with severe OCD not responding to SSRIs, probably clomipramine is a good drug of choice. You might want to continue benzodiazepines in this subgroup for probably a longer period of time as compared to what you do in a major depressive episode. And you can choose any benzodiazepine that you're comfortable with, clonazepam, alprazolam, etizolam, or lorazepam. From a clinical perspective, anything is okay. What if it does not work? Go back and reevaluate the diagnosis. When we talk of antidepressants for treating major depressive disorder, we said about 4 to 5 weeks is an adequate trial. But when you're looking at anxiety spectrum disorders, which specifically OCD, then one has to give in at least 8 to 12 weeks at optimal doses before deciding to change it over to another class of drug. So if I had started somebody on fluoxetine, and I would gradually optimize the dose to 80 milligrams per day over a period of 6 weeks time from the time of starting treatment, I would wait for at least 8 to 12 weeks on 80 milligrams. So that means I'm probably considering about 3 months at least being on drug one. It's very important for us to educate our patients that unless they take an optimal dose, they're going to keep changing drugs with limited response to any number of medications that they tend to take. Of course, you could change to another drug. Combinations, again, the evidence is less robust. Unless people don't respond to multiple monotherapy trials, combination is not advocated. Of course, CBT is a big area of treatment. We'll not get into that. Most anxiety disorders, if you have somebody, you've defined the episode, treat for at least 6 to 9 months. And if there are multiple episodes, consider a long-term maintenance medication. OCD, you need to look at least 2 years of remission before considering tapering down of this medication. It's very important, again, because a lot of our neurology colleagues do end up seeing a fair amount of anxiety spectrum disorders, which also includes OCD. So make sure that you're discussing the possibility of a long-term maintenance medication, and always taper gradually over a period of time. I think I'm just going to get a couple of slides in the last part of the presentation. How do you manage a pharmacologically and acutely agitated patient in the ward? This is probably one of the commonest calls that we end up getting in a general hospital setting. Try and define the syndrome. Of course, we always look at something pathological, but strange it has been. We've seen being called to see an acutely agitated patient because he was agitated because there was a rat in the bathroom, and he was agitated because the nurses weren't attending on to him. So we need to be clear that is this normal or a reactive mood state, but I think delirium, acute psychosis are the commonest presentations in the ward, and of course, rarely acute mania. And this I'm talking in terms of a patient who's been admitted for other neurological conditions now presenting with new onset behavioral change. Multifactorial delirium and not solely substance withdrawal delirium, that is again the largest a group of presentation. A small isolated group of presentation is purely people presenting with substance withdrawal, especially alcohol and benzos, presenting either with delirium or with seizures to the neurology emergency, and of course developing acute psychosis in the hospital-based setting. When we look at a pure alcohol or a pure benzodiazepine withdrawal delirium, lorazepam, chlordiazepoxide, diazepam, any of these molecules are okay. If there is a compromised liver state, then probably better to go with lorazepam, both oral and parenteral. Generally, as a routine, when we see people coming in with deliriums, we start off with injectable lorazepam. We go with about 4 milligrams IM or very slow IV. We go about 4th hourly or 6th hourly, and then titrate the dose accordingly. Chlordiazepoxide, you can go up to anywhere between 150 to 250 milligrams per day, depending on how severe the presentation of delirium is or how severe the addiction was. Diazepam as well. Once the delirium resolves, you need to gradually taper and stop. But the larger subgroup is the multifactorial delirium, where there is more than one cause. So there could be somebody with a stroke who also has hyponatremia, has also had a seizure. And the pharmacological management of behavioral symptoms in this subgroup is only to symptomatically control the agitation. It is not to, the primary treatment is treating the primary medical condition, but we might want to use quetiapine anywhere between 25 to 100 milligrams per day, risperidone about 0.5 to 2 milligrams per day, olanzapine 2.5 to 10 milligrams per day. And if very severe agitation, then probably consider parenteral haloperidol. You can wean off these medications once the symptoms resolve, and very rarely do you really need to look at a long duration treatment. Maybe sometimes with post-stroke behavioral syndromes, you might need to look at a longer duration of an antipsychotic drug. And of course, a new onset acute psychosis developing in the hospital. Here you might want to treat with more optimal doses, risperidone anywhere between 2 to 6 milligrams per day, olanzapine about 5 to 20 milligrams per day, and quetiapine anywhere between 100 to 800 milligrams per day. But you will go ahead and optimize the dose gradually and not start at 600 or 800 milligrams per day. When a patient presents with a new onset acute psychosis, unlike with delirium, where you gave antipsychotics for acute control of behavioral symptoms, you may want to continue the antipsychotic here for a couple of months. And I think as neurologists, you probably are already well aware of all the possible side effects that you tend to see with antipsychotic drugs. So when is the need for referral? Somebody is extremely agitated. There is a potential risk of harm to self or to others. There's poor self-care. If there are multiple episodes, relapses, there is a diagnostic ambiguity, and if there is pregnancy and severe mental health related issues. So to conclude, always good to define a diagnosis. A lot of neurology residents who get posted with us, that's what we talk to them. Treatments are usually prescribed, but a diagnosis is not given. Very often you see the jargon of psychiatric problem and anti-psychiatric treatment that is being documented onto case sheets. I think we should strictly go away from them. It's important not to just be a prescriber, but also discuss the diagnosis, talk about the role of medications. We also understand one of the biggest challenges is the iatrogenic benzodiazepine prescriptions that tend to go on, and then patients developing benzodiazepine dependence over a period of time. While psychopharmacology is important, rational use is also absolutely necessary. Thank you.
Thank you. Thank you, Dr. Vijay Seshadri, for a very comprehensive and a very useful lecture, which is very relevant to us in our day-to-day practice. Most of the questions have been answered as I was looking at the questions, but you know, these topics need much more discussion, and I think I will request Sudhir that eventually we may need some more lectures and more discussion. But thank you so much. It was, both the speakers did a wonderful job. Thank you once again. We are not going to have a question answer session. If at all there is any question which has not been addressed, we will send it, we will email it to the speakers and they'll get back to us. So thank you once again, both Dr. Srikanth and Dr. Seshadri. Thanks a lot. Now with that, I hand over to Dr. Sudhir Kothari for the next session.
Thank you. Excellent session, Subhash. Very much needed. We are now beginning the first talk of a series of 3 talks on genetics for neurologists. And we have with us Dr. Radhika Damicha. She's from the Mayo Clinic, Arizona. She's studied from the All India Institute and then has gone and done boards in both neurology and genetics. So we have somebody who can, I've been looking for somebody who can teach neurologists how to use genetics, and I think she's the perfect person to do that. So without much waste of time, Radhika, this screen is all yours.
Okay, thank you, Dr. Kothari, and thank you for inviting me. So I know genetics can be very new to many neurologists. So what I did is I put together a few questions that I'll use a polling to see where everybody is in terms of their knowledge. And I'm starting from very basic, so I can go as detailed or as basic as I feel based on how the poll goes. So there are about 7 or 8 questions that I'll start before I'll go into my talk. So here they go. Hopefully this will work.
For those who have not yet used Slido, either install Slido in your phone and then enter this number N960, or on your phones, open the browser, go to slido.com and enter this number. So if anybody has a problem joining, just raise your hand. We'll give you 2 minutes to join. If there's anybody who has a problem, just let us know. So join at N960. And once you join, you go to the polls. You have to enter your name. Radhika, you may have to reset the poll. Go to the... Yeah. Yes. Okay, so I think most people, nobody's raising their hand, so we can begin.
Okay, so this is the first question. You get 20 seconds for each question. So which of the following methodologies has the highest resolution for detecting a genetic change? Okay, we'll go to the next question. Which of the following methodologies can be performed without requiring a sequence-specific probe? Right? And then Human Genome Project was completed in which year? A 15-year-old girl has a diagnosis of NF1 and has numerous cafe au lait macules, freckling, and neurofibromas. Her mother had only few cafe au laits and no neurofibromas. Which phenomena explains this finding? It's a long question. You only get 20 seconds. What is the most common mode of inheritance of mitochondrial disorders? This is a trick question. a genetic disorder that occurs in males and females equally, yet is rarely seen outside of relatively isolated populations or cultures where consanguinity is common is most likely. Which is most likely explanation of why Huntington disease tends to get progressively worse with each generation. Okay. And this pedigree represents which mode of inheritance? Okay, I think that was the last one. I think you did fairly well, I would have to say that. But I'll open up my presentation now, and then we'll come back to these questions in the end if we have time, or if you have any specific, I mean, the answers are all there. So hopefully you'll all get 100% at the end of my talk. So I have my email on the first slide if you ever need to get in touch with me to ask any questions later if we can't do them in this hour. But the objectives of this talk, we're going to cover really basic DNA structure and some molecular genetics. We'll cover Mendelian inheritance. We'll cover some basic technologies, both in cytogenetics and molecular genetics, as it is useful for neurologists. And then we'll spend some time discussing new technologies. So before going into the DNA structure, we'll start with some definitions. So what is genetics? Genetics is essentially the study of specific individual genes and their role in inheritance. And genomics is a study of an organism's entire genetic makeup, that is called a genome, and how that interacts with the environmental or non-genetic factors, for example, lifestyle. And genomics is really applied to the study of complex disorders such as cancer or diabetes, heart disease, and hypertension. And we're really not going to focus these disorders for the purpose of our talk. We'll stick to Mendelian disorders. And genomic medicine is a medical discipline that involves using genomic information about an individual as a part of his or her comprehensive healthcare, which could be for diagnostic purposes or even therapeutic decision making. So really, we have come a long way in genetic discoveries. If you think about it, really Mendel's principles of genetics were first described in 1865. And to think about from 1865 to when the first human genome was sequenced was 2003. So the highlights of what happened in this century include the discovery of the DNA structure in 1953. In 1977, there was discovery of Sanger sequencing. In 1985, PCR was discovered. And really after that, the newer technologies, including next generation sequencing, which came about in 2004, followed which the first human genome was sequenced in about 2008. And now we can really sequence any patient's entire genetic information. So this is a cartoon I like to show when we're talking about genomes. So if you think about a book, it is equivalent to the genome. And the genome is made up of chromosomes, so 23 pairs of chromosomes, and each chromosome you can consider them as chapters. And then we're talking about gene, you can really equate it to like a sentence in one of the pages. Very simplistic view. So DNA, if you may recall from way back in medical school, it is made up of purines and pyrimidines. There are two purines, adenine and guanine, and there are two pyrimidines, thymine and cytosine. And they're arranged, or they're paired in a double helical model shown here. And there are hydrogen bonds between cytosine and guanine, and 2 hydrogen bonds between adenine and thymine. Now, the DNA structure that I just described is right over here. So it's a DNA duplex, and it gets coiled really tightly. And if you remember, these proteins are called histone proteins, on which this DNA is tightly coiled, and this coiling becomes even more tighter and tighter. And finally, you get something that looks like this, which is a metaphase chromosome. So the most condensed phase of mitosis, where you can study the structure of chromosomes, and this is called metaphase. So this is another way of looking at how chromatin packaging occurs in a human chromosome. So you start here from a double helix DNA that I showed in the first slide, and then you condense it over histones to make these nucleosomes and further condense it. And then this is how the chromosomes would look like when they're not in their metaphase. So this is an interphase where they're not condensed. The other things to know is that each chromosome has some structures or names or nomenclature that we will use as I'll describe disorders or technologies. So P arm is the short arm, P stands for petite, and Q arm is the long arm. Telomeres are the ends of the chromosomes. Centromere is where the sister chromatids kind of meet. So I think these few terms are important to know, and you probably already know them. And then again, these are the histone core proteins along which the DNA is coiled. And this histone structure becomes important as we will review some methylation disorders. So how this, again, there are these histone proteins that have these side chains where DNA can get methylated. And one thing to remember is when DNA gets methylated, that means the gene is silenced, it won't express itself. And again, this becomes important in some imprinting disorders that we'll review in a minute. So reviewing again the basic anatomy of the chromosome, again, there's the short arm of the P arm, the long arm of the Q arm, and then each chromosome has these numbers. For example, you may have heard of say chromosome 15 disorder. So it's actually the 1 stands for the arm, the P stands for the arm, the 1 number stands for region, band, and subband. That's how we know that where in the chromosome an error happened, so deletion happened or duplication happened. So we would read this out as chromosome 15, P arm or the short arm, 12.31. So at region 1, band 2, and subband 3.1, there's an error that happened. This is important to know because that's how you get chromosome reports to look at when you order them. So this is a standard human karyotype. So this was the first test that we all kind of studied in med school, trisomy 21 or patients with Down syndrome, or trisomy 18 or trisomy 13. This is really how they're diagnosed. So you take the cell and you look at the chromosomes in the mitosis, in the metaphase, which is the most condensed phase of the chromosome, and you look for errors. Say there's an extra chromosome 21 or extra chromosome 13 or 18, and that's how patients were diagnosed with aneuploidy or chromosomal disorders. One other concept that it's important to note as I go in the subsequent slides is the human genome does not only include the nuclear genome that I just spoke about. It also has mitochondrial DNA, and each cell has hundreds and hundreds of mitochondria, and mitochondrial machinery kind of runs on its own. And so it's important to know that when you're looking at a patient's human or genome, then we're talking about both the chromosomes and also their mitochondrial DNA. Now, does DNA get transcribed into RNA? And finally, RNA is processed into mature RNA, and RNA makes proteins. So the human genome is really made up of full letters, A, G, T, and C, and these full letters are arranged in different sequences and condensed in its entirety in every cell. gene is the basic unit of inheritance, and chromosomes are linear organization of genes. All of us have 23 pairs of chromosomes, and one set of each we get from our mom and one set we get from our dad. And as I said, genome is all the DNA of these chromosomes within a person. And why it is important to know that we get one set from mom and dad becomes important as I will go into exome sequencing. So again, you get one set each from your mom and dad, and that's how a complete set is created in a child. Now, the first test that we all kind of are familiar with is chromosomal analysis. So chromosomal analysis, when you order on a patient, is essentially whole genome coverage. So you are looking at the entire patient's genome and their genetic information, but it is at very low resolution. So only if a change can be detected under the microscope in the metaphase is when you will be able to pick it up. So we say that it is the lowest resolution, even though you can say you're looking at the entire genome. So that's test number one. Now, test number two is something called FISH, or fluorescent in situ hybridization. So essentially what this test is, say you know what you're suspicious about. For example, say you were evaluating a patient and you were worried about DeGeorge syndrome or chromosome 22q deletion syndrome. So there's already a probe that you will create for that site, and you will see how many signals you get in the patient. So as you know, each gene has two copies, one you got from your mom and one you got from your dad. And if one copy is missing, you can say that that patient has a deletion. So this is site specific, though it has very high resolution because you can make probes for a single gene. So we say that FISH has high resolution, but it is site specific. Now, chromosomal microarray, this is obviously a newer test, many years now, but is really routine, at least in pediatric neurology practice, for evaluation of developmental delay or even epilepsy. So essentially, the way I look at this test is hundreds and hundreds of FISH in one testing. So you have all the chromosomes and you have created probes for different sites in all these chromosomes because you know the regions on the chromosomes that are important. And you compare the patient's DNA with a reference DNA and see if there's a signal increase, so duplication, or a signal decrease or deletion. And I have better pictures or bigger pictures that will kind of describe it. So coming back, this is, the books that I initially just kind of showed you. So this is trisomy 21, easy to detect on a metaphase or standard karyogram. You don't need any fancy testing for it. So you have extra copy of 21. Even if the patient has large gene deletions, for example, loss of chromosome at 5p or short arm of 5p, it is called Cray-Duchenne syndrome. You can detect it on a metaphase karyogram because it is a large deletion, so you can't really miss it. It's visible under the microscope. This is an example of a locus specific probe, which is called the FISH testing. So you created probes and each allele or each gene has two copies, so there should be always two signals for each. And if one is missing, you say it's deletion, or if there's one extra, you say it's duplication. So this is FISH. And this is what chromosomal microarray really pictorially looks like. So you have your 23 pairs, 1, 2, 3, 4, all to an X and Y. And you have these specific, I really say it's hundreds and hundreds of FISH testing in one testing. So you have these probes against important regions on the chromosomes where we know if there's a deletion or duplication, a patient will have a phenotype. And then you compare the patient's DNA with the standard or a reference microarray. So again, this is a more detailed explanation of what a chromosomal microarray looks like. You have the patient's DNA, you have the control DNA, you put them both against the microarray chip that you have created at standard. We've already created this standard chip that has important probes against important regions of all 23 pairs of chromosome. And then you look for signal loss, as I said, deletion or signal gain. Very simplistically, this is what chromosomal microarray is. And it will give you, say, for example, this is chromosome 7 plot, and the patient is this purple, and it is below the reference line. So it means there's a deletion on chromosome 7. So this is another way of looking at the microarray. Again, the signal, the report that we get, or when we are in the lab, that's how we get it. You get these signals and you say if the patient is above the reference or below. So it's duplication versus deletion. So the same testing, so this patient has trisomy 21. There's 3 ways of getting a diagnosis of trisomy 21. Hopefully, you can all diagnose Down syndrome clinically, but in order to confirm it, this is a metaphase spread. So this is the patient's metaphase. You have 1 extra 21. Say if you had ordered a FISH testing, you get 3 signals for the probe on chromosome 21, so that 1 extra. And then if you had ordered a chromosomal microarray at chromosome 21 probe, everything would be at higher noise or higher signal than the reference. All the other chromosomes in reference are at 1. However, chromosome 21 is higher. So even a chromosomal microarray can detect a trisomy, though it would not be a traditional way to order it, but you can certainly detect it if you were to order a CMA. So chromosomal microarray, really we use the acronym as CMA. So this cartoon shows here chromosomal aneuploidy. So aneuploidy means when you have extra chromosomes or fewer chromosomes, so like trisomy or monosomy, they both will come under aneuploidy. So you can detect an aneuploidy with both a karyotype and a CMA or a chromosomal microarray. You can detect a large deletion or duplication as well on a chromosomal microarray and a karyotype. The only thing that really a chromosomal microarray cannot detect that a karyotype can detect, which is important sometimes in clinic, certain very specific clinical situation, is if you have a balanced translocation. So if you remember, balanced translocation is a chunk of a chromosome from one kind of breaks off and sticks into the other chromosome, but the net genetic information in the patient remains the same, so it's balanced. So balanced translocation cannot be detected by a chromosomal microarray, because if you remember, chromosomal microarray only tells you signal from the reference, but because the genetic information is balanced, it cannot tell you if it's, it cannot tell you because there's nothing missing or duplicated. So I think that's an important point. Sometimes we get tested on this. So coming to sequencing. So sequencing has evolved a lot. So sequencing used to be done, well, it's still done in some situations, but you may hear about traditional Sanger sequencing. And then now we have essentially very large multi-gene panels, and we use what we call as next generation sequencing technology to build these multi-gene panels. And then whole exome and whole genome sequencing are again 2 other ways where next generation technology has been used to analyze exome and genome. So what is next generation sequencing technology? So I need to explain to you before we can kind of understand how that has been used for both exome, genome, and large gene panels. So you take a patient's DNA, we call it genomic DNA. You break that DNA into hundreds and hundreds of very small pieces. So when I say small pieces, they're about 100 base pairs or 200 base pairs, so very small. And then we already, as you recall, we already sequenced the human genome in 2003. So we know what the human genome is supposed to look like. So that is the normal reference genome, or not normal, I should say, it's a reference genome. And these small pieces of the patient's DNA that you have sequenced or broken down, you kind of align them against this reference genome, and you come up with a sequence. So that's the very simplistic way of how next generation sequencing works. You take a patient's DNA, you chop it off into hundreds and hundreds of pieces, you align it with a reference genome, and then you sequence and see what the patient's DNA reads compared to the reference DNA. And that's how you find mutations or variants. Now, how is exome different from genome? I think it's important to know. So exome is a very, very, very small part of the whole genome. Exome is under 2% of a patient's genome. but over 85% of Mendelian disorders arise from that 2% or exome. So that's why our first step is usually whole exome if we have to do it, and we don't really jump straight to whole genome, though sometimes we do. So genome is obviously way more information or base pairs than an exome, but a lot of it you may kind of remember, we used to use the word junk DNA. So that's really what we meant by junk DNA. Only 2% of the entire genome is useful in its exome, though it's not entirely true. There's a lot of information even in the so-called junk DNA, but that's what used to be called junk DNA, and that's why exome is so small. This is another cartoon, is kind of my favorite. So if you think about the whole genome as an apple, then exome is really a small slice of that apple. And when we do whole exome, that's what we're looking at. So DNA is made up of exons and introns. Exons code for protein, so that's why they're important. We also know that 85% of Mendelian or genetic disorders arise from problems in the exon. Each exon is interspersed with an intron, so introns kind of are after each exon, but we don't know a lot of what introns do. We are starting to learn more and more, but that's how it is. There's more junk or non-informational DNA still, and we know less. Now, we talked about next generation sequencing technology. So next generation sequencing technology has been used to either do whole genome sequencing, or it has been used to do whole exome sequencing or target panel sequencing. So essentially why we use next generation and not Sanger is because Sanger is extremely slow, labor intensive, and probably way more expensive because it is so slow and requires really manual labor. So we really do next generation sequencing, labs, I should say, do next generation sequencing now. And when I say, what we mean by capture or no capture is if you really look at everything, so these colored rectangles are different exons and everything black is introns. So if you look at everything and you don't really pick and choose, you get your entire genome. If you only pick these colored boxes, these are the exons, you get whole exome sequencing. And then neurologists have become really smart, I should say, and we've created different panel testing, so we can do epilepsy gene panels or dystonia gene panels or ataxia gene panels. They're really commercially available. I know obviously they're available here, but I also know that even in India, many genetic labs have come up and they're offering testing. So, and that's called targeted gene panel. So you have curated a list of genes, and you're using the next generation to sequence all of them together because it's quicker. It's not that expensive actually to sequence many hundred genes together than one gene after the other. And I think in my second or third talk, I'll talk more about cost and those things. So genetic testing bias. So way of thinking is, should you look at the hay by a handful for anything that might be sharp, or should you look through the whole hay stack for the needle? And actually looking through the whole haystack for the needle is more cost-effective, time-effective, and is, I think, better in our field. So these are just some examples of how we have created so many different panels: a neuropathy panel, dystonia, Parkinson's, motor neuron disease, dementias, leukodystrophies, epilepsy, attacks, you name it, really. As long as you're comfortable with defining the phenotype, there is a gene panel available for it. So as long as the phenotype has been described correctly, I think it's easy enough to choose a panel. There is certainly a role for single gene testing with some very specific disorders, but more or less the phenotypes are tight, but the genotypes are so broad that we either do disease-specific next-generation sequencing, or in some situations even do whole exome sequencing as the first step. More so in pediatric neurology, I would have to say, though. Now, in terms of yield of genetic testing, why is genetic testing done? What is the yield or positivity in the right patient? So when we only had the carrier type available, the yield of genetic testing was really it was about 5 to 7%. So if you tested 100 people, you'll maybe find chromosomal disorders in 5 to 7%. That's it. That was the end of the story. With whole exome sequencing, it's still very modest. It's about 30 to 40%. So even now, with everything that is available in the field of neurogenetics, the diagnostic yield can only be provided in the right patient in about 30 to 40% of the cases. The vast majority still, unfortunately, are not provided with an answer, but it is extremely high compared to the traditional testing of chromosomal analysis that we had really 15 years ago. So from 5% to 40%, I think that's pretty impressive. So in order to help you understand which has highest resolution, so karyotype certainly, as you know, probably makes more sense now, that has the lowest resolution. And as you go to FISH, CMA, which is chromosomal microarray, and then whole genome or whole exome sequencing, you increase the resolution. And you don't need any probes for whole genome sequencing. You certainly need a probe for FISH and chromosomal microarray. So that was another question that I had. So that was the first part of my talk. The other important point I wanted to highlight is, why do we do panel testing these days? There are two important concepts that are important to note. One is of what we call genetic heterogeneity, and one is what we call phenotypic pleiotropy. So let's understand what genetic heterogeneity means. So classic genotype-phenotype concordance means you have one genotype and you have one phenotype. So for example, patients with trisomy 21 or Down syndrome across ethnicities look exactly the same. You really, as a physician, should be able to see a child with Down syndrome and say the child has trisomy 21. There is no other chromosome that typically would mimic Down syndrome. So that's a very tight genotype-phenotype. It doesn't really happen that way in most genetic disorders, other than maybe some chromosomal disorders. So for example, you have a phenotype, you could have many genes that produce the same phenotype. A very classic example is something called hemiplegic migraine. So in hemiplegic migraine, patients' phenotype is pretty similar. They get hemiplegia and they get migraines, but their genotype could be very different. They could have a calcium channel mutation, they could have a sodium channel mutation, they could have an ATP channel mutation, or they could have PRTT2 mutation. Now, if a physician sitting in the office can diagnose hemiplegic migraine, but there's no way a physician looking at that patient with hemiplegic migraine can say which of these genes is mutated. So you have to do a panel. So this is what we call the concept of genetic heterogeneity, meaning the phenotype is caused by many different genes. Just the opposite is a phenotypic pleiotropy. So for example, you have one genotype, one gene, but it produces many different phenotypes. For example, a patient with a mutation in ATP183 gene, it is a channelopathy, it is a channel gene. It can produce 3 different phenotypes, as we know of today. It can cause alternative hemiplegia of childhood. It can cause rapid onset dystonia, Parkinsonism, and it can also cause infantile epilepsy. Now, you could have a family with this gene mutation, and different patients could have different phenotypes. There was no way you could have linked them to this gene unless you did either whole exome or a panel testing. So these are the 2 big reasons why in neurology and many other subspecialties, you really order panel testing and not one gene after the other, unless the phenotype and genotype was very clear. For example, a patient with neurofibromatosis type 1, there's nothing else that would look like that typically, and so you would just order NF1 gene testing. The other things to remember in exome sequencing, and this is more to do with the technology and how it's done, you cannot diagnose trinucleotide repeat disorders on exome sequencing. So trinucleotide disorders like Huntington disease or SCAs, spinocerebellar ataxias, you can't diagnose them. And for practical purposes, even large deletions or duplications cannot be detected on exome sequencing. So based on what we have learned in terms of technology and testing, this is how you would classify genetic disorders. So you have chromosomes, which are made up of DNA. You have genes on the chromosomes, and then genes could be, as I explained to you, the methylation of those histones can silence them, and they may not produce the protein, or they may produce the protein. So if a large chunk of chromosome is missing, or there's some abnormality, this is called chromosomal disorders. For example, your trisomy 21. If a small piece of chromosome is missing or duplicated, for example, 22q11.2 syndrome, you call them microdeletions. So these are the disorders you can detect by chromosomal microarray. Now, if a gene doesn't function well, a single gene, you call it a single gene disorder. For example, neurofibromatosis type 1. And if the gene was supposed to make the protein, but for whatever reason it doesn't, we call them epigenetic disorders. So like imprinting disorders, Prader-Willi syndrome or Angelman syndrome. So those are classic examples of epigenetic disorders. So these are like 4 categories you could place most genetic disorders in. And then we also talked about the technology that can help you diagnose these disorders. I'll briefly talk about imprinting disorders, because I think in neurology there are a few that kind of show up in boards. Prader-Willi and Angelman are classic examples. So DNA methylation is what really goes abnormal in these imprinting disorders. So DNA methylation, you have these cytosine residues in DNA that gets methylated, and when something gets methylated, it is silenced. So it doesn't make protein. So one classic example of this is X chromosome inactivation. You may recall that in females there are 2 X chromosomes, and one of them is always silenced, only one expresses. And how that one X is silenced is by DNA methylation. And the other DNA methylation disorder is the Angelman and the Prader-Willi syndrome. And I'll explain to you with the help of this diagram, because it can be a little tricky. So normally on the chromosome 15, there is a region. So this is normal. You kind of walk with me. So this is normal. This is a Prader-Willi region on the chromosome 15, and this is the Angelman syndrome region. Angelman syndrome region on chromosome 15. In normal cases, only one of these copies is active. The other is methylated. So on the maternal copy, the AS region is active, and on the paternal copy, the Prader-Willi is active. Now, when a mutation happens, that the paternal copy is deleted, that's how you get the Prader-Willi syndrome. And when a mutation happens, that the Angelman copy is deleted on the maternal, you get the Angelman syndrome. So these disorders kind of are extremely different. Prader-Willi has a very different phenotype than the Angelman syndrome, yet they're both caused by the same chromosomal disorder. And the reason is, in one case, the paternal copy is missing, in the other case, maternal copy is missing. So that's why it's important to know that you're both copies, you get one from dad and one from mom, and they're kind of important differently because many of the genes are only expressed from one and not from the other. Imprinting disorders are kind of tricky to remember. So I think as long as you understand that there's something called imprinting, and sometimes these disorders happen because of deletion on paternal copy or maternal copy because they function differently, I think that's kind of enough. Now we'll come to some basic inheritance modes. This is easy, hopefully. So we will focus on Mendelian inheritance. As you may all recall, Greg Mendel did some P experiments way back in 1856 from 1863, and he established the basic inheritance concepts or Mendelian inheritance. There are four inheritance patterns that we will talk about: dominant, recessive, X-linked, and mitochondrial. In the genetics clinic, patients, when they're seen, typically they should get a pedigree drawn out. If you may see some pedigrees and you will see that squares are males, circles are females. Anything that's colored means it's affected. Anything that has a dot means they're carriers. So not wholly affected, but they're carriers. And then there are other symbols that some of them you may want to know. If there are two lines between mom and dad, it means that they're related, so consanguinity. And then if there's an arrow for a box, it means it's the proband. So important concepts in autosomal dominant inheritance: affected individuals happen in successive generations because it's a dominant disorder. Both males and females are affected equally. New mutations may occur in an individual without affected parents. And so even if there is no family history, you can have a new mutation. And there is variable expressivity within family. So for example, I had that question on NF1 where the patient had all the features of cafe au lait and freckling, but mom only had maybe a couple cafe au lait and maybe 1 year of fibroma. So that is not incomplete penetrance, that is variable expressivity. So incomplete penetrance would be when you would not have any phenotypic feature, while variable expressivity means you have expression, but it is variable. And neurofibromatosis type 1 is a disorder that has complete penetrance, but it has variable expressivity. So that was something I discussed in that disorder, in that question. So the other group of disorders that as neurologists we come across is trinucleotide repeat disorders. So examples of them are Fragile X, Huntington disease, spinocerebellar ataxia, and myotonic dystrophy. And these disorders are all dominant disorders. And they do have something called anticipation, which means that each successive generation, the phenotype gets worse. So the disease starts earlier, and it could also be more severe. And the reason why the triplet expansion happens is because of error in DNA replication called slippage. So this is an example of Huntington's disease mutation. So because these mutations change with generations, we also sometimes use the term dynamic mutations, meaning that they change. So these repeats are unstable. Normally, a patient should have only equal to or less than 35 repeats of CAG in Huntington, for Huntington gene. But if the patient has greater than 40, that's when the patient will express the disorder. And greater the number of repeats, earlier the age of onset. So as you see, the graph goes like that. So the number of repeats increases, the age of onset is less. So genetic anticipation, I briefly mentioned before, happens when trinucleotide repeat disorders due to instability result in increasing severity with successive generation. For example, this is a HD family, everybody who's colored is affected. So a lot of people affected, but as you can see here, even a child has symptoms. And in this generation, the onset was 22, alive at 64. So essentially it shows when it started and the patient died. Coming to recessive disorders. So recessive disorders, if you look at this pedigree, the half colors means they're carriers. So this patient is a carrier, this person is a carrier. They came together and they had a child who's affected, a child who's not affected, and then 2 children who are carriers. So greatest recurrence risk happens among siblings of affected individuals, certainly. Again, there's no gender preference. Males and females are equally likely to be affected. If parents are both carriers of the same recessive gene, then each pregnancy has a 25% chance of normal gene, 25% chance of affected, and 50% chance of being carriers. And again, consanguinity and ethnic background does influence the specific group of disorders because there's higher chances of 2 carriers coming together. So that was another question I had in the pre-test. Now coming to X-linked recessive disorders, this is another interesting group of disorders where both males and females can be affected, but females are usually very mildly affected just because of the phenomena of X-linked inactivation that I mentioned because of methylation. So females have 2 X chromosomes, but only 1 X is expressed, the other X isn't. So X-linked recessive disorders in females, they are called carriers, though they can have mild features of the disease. So incidence is much higher in males than females. All daughters, so here of an affected male will be carrier, because as you know, the female will get the X chromosome from the dad. So the affected dad will pass the affected X chromosome to the female. And the condition, again, when you look at the pedigree, and if the condition can never be transmitted to from father to son, so that's another clue for X-linked transmission, because the son would get the Y from the father and the normal X from the mom. So the son would never have an X-linked disorder transmitted from father. Now, a few examples pertinent to neurology I kind of listed here that you may know. Are X-linked is Fragile X, Duchenne's muscular dystrophy, X-linked adrenoleukodystrophy, or AMN adrenomyeloneuropathy, which is again the adult version, and even females present with AMN. Rett syndrome is X-linked, and then Hunter's disease, which is a lysosomal storage disease, is X-linked. Actually, one very important disease that's missing, and this is Fabry's disease, which is also X-linked and can present with strokes in young people. So coming to the last group of Mendelian disorders is mitochondrial disorders. So first, before I go into the inheritance of mitochondrial disorders, I thought I'll spend a few minutes discussing the mitochondria. So mitochondria, as we know, are the principal source of energy for all cells, except RBCs. Each cell contains hundreds of mitochondria, and the mitochondrial DNA is really very small. It really has only a small DNA that makes 37 genes. So mitochondrial DNA in itself is very small, but there are over 1,000 gene products in the mitochondria. So rest of them are encoded by the nuclear DNA. I think that's an important concept to remember. And I have this slide that tells you how many genes are involved in mitochondrial machinery. So you have this mitochondrial matrix, you have outer mitochondrial membrane, you have inner mitochondrial membrane, you have the intermitochondrial space, and then so many other proteins. This is just a very modest list of proteins or genes that make proteins for the mitochondrial machinery. But as I showed in the previous slide, only 37 of greater than 1,000 are encoded by the mitochondrial DNA. So why this is important? So mitochondrial DNA is what is transmitted in a mitochondrial inheritance fashion, but the nuclear DNA is Mendelian, so it's mostly recessive. So most mitochondrial disorders are actually recessive inheritance and not mitochondrial. So that's where this concept of dual genome origin comes in. So dual genome means the mitochondrial DNA machinery or mitochondrial machinery is run by this nuclearly encoded DNA and mitochondrial DNA. So this follows, the mitochondrial follows the maternal inheritance that we classically know of as mitochondrial DNA, but the nuclear will follow Mendelian. So it could be recessive, dominant, X-linked, but most of the time it is recessive. Mitochondrial DNA is exclusively inherited from the egg. There is no contribution from the sperm, and hence this is how a mitochondrial pedigree would look like, that if a boy or a male has a mitochondrial disease, they cannot pass it on to their children, while if a female has a mitochondrial disease, because they pass on abnormal mitochondria to all their children will be affected, though again the severity could be mild to severe. And here, the severity depends on something called heteroplasmy. So heteroplasmy is, again, an important concept for mitochondrial inheritance. So let's kind of walk through this graph here. So this is a mom. She has very mild symptoms, or let's say no symptoms at all. The red mitochondria are mutated mitochondria. So mitochondrial cells may have 20% of, mother cells may have about 20% of mutant mitochondria, and yet she may not have symptoms. So this is mom's DNA. As eggs are being made, these red or the mutated mitochondria may pass on in different numbers. And if you know, mitochondria are autonomous, so self-replicating. So a cell with fewer bad mitochondria will end up having less amount of mutant mitochondria, while a cell with greater number of mutant mitochondria will have more. So this is called heteroplasmy. And so a child could inherit 80% of mutant mitochondria and they would have severe disease, while a child could have only 20% of mitochondrial disease, mutant mitochondria, and would have no disease. So this is called heteroplasmy, which is essentially a way we tell you what is the ratio of mutant mitochondrial DNA to normal DNA. And it actually can vary from cell to cell. We can check it on the tissue that's sent for testing. So for example, a mitochondrial patient has blood testing. You could tell them what is the heteroplasmy for WBCs, but that doesn't mean that their cardiac cells or the brain cells or liver, whatnot, have the same amount of heteroplasmy. It's really tissue specific. And so that's how sometimes the patients with very low heteroplasmy in their blood still could have severe symptoms in their liver or brain. But this is a rough estimate of how many mutant mitochondria they have. So that's the end of the mitochondrial inheritance. Now there's also something called multifactorial inheritance. So most disorders that we deal with as physicians in the clinic are multifactorial. Mendelian are few. So multifactorial, there's an interaction of genetic factors, environmental influences, and so we think of medical disorders being as a continuum. So there are some disorders that are purely genetic. For example, we talked about Huntington disease or Fragile X and things like that. And then there are disorders with some environmental influence. For example, patients could have predisposing genes for dementias, but say they change their environment or disease modifying things and they may not develop it. However, then there are disorders that are purely environmental. So I think this is a spectrum, but these are some examples of multifactorial inheritance. So they could be mental illness, diabetes, MS, dementia. They're all kind of multifactorial for most part. I will skip that. The other, I had this slide on pre-implantation genetic diagnosis. So I think one question comes is what can be done sometimes with this genetic information. So the neurotechnology that is used really quite commonly now for many severe genetic disorders is something called pre-implantation genetic diagnosis. For example, if there is a family, say with, let's say Huntington disease, that it's a dominant condition, so anybody who has it has a 50% chance of passing it on, but they want to choose not to pass it on and they want to have children the normal way. So essentially you offer them what we call as pre-implantation genetic diagnosis, so something similar to in vitro fertilization. So they go through that process of in vitro fertilization. And then once the embryo is at the blastocyst stage, you remove or you check for the DNA mutation and then only implant the embryo that doesn't have the DNA mutation. So that's one kind of application of genetics early on where you may be able to avoid passing on a severe genetic disorder in the family. So I think that's kind of what I had for today. Genetic diagnosis and inheritance. I'll stop here. If we have time, we can, I think we're kind of over time already, so we can not do the after questions or the pre-test questions again. I'll take any questions if anybody has or
Sudhir, hi, I'm Roop Gursahani. I'm waiting for Sudhir to appear.
Oh, okay.
Can you hear me? Yeah. Hi. So there are some questions on the chat. I'll quickly run through them. Do you want to open them yourself? Or one is NGS is second generation sequencing with Sanger being the first. What is third gen and is it still commercial? Is it already commercial?
Okay, let's see.
Did you see it?
Yeah, we typically use second generation or next gen sequencing clinically. I'm sure there are more sequencing technology that are in research, but not commercially available. I think that kind of answers that question.
Is Sanger really, I mean, is there any advantage to doing Sanger? I mean, if you look at all the manual effort, is it really,
I think Sanger sequencing has a place. So sometimes when we do next generation sequencing and we find variants, sometimes we use Sanger to actually confirm that those variants are real. And Sanger sequencing is also used, for example, you're only ordering a single gene testing, for example, as I gave an example of NF1 or neurofibromatosis 1 testing. So when you order testing, they're not going to do next gen for that. We can order Sanger sequencing for single genes. So I think it still has a place. But for vast majority, I think we're all into next generation sequencing. Which is more confirmatory, Sanger or next generation? You know, I mean, as I said, both have their time, both have their place. To confirm next generation, we sometimes use Sanger. Sanger is, it is confirmatory. If you see a variant in Sanger, it is a true variant. But in next generation sequencing, because of some limitations, you may have to do Sanger to confirm it. So out of the two, I would say both are confirmatory, though Sanger is gold standard.
Okay.
Yeah, I had one question. There is a, I mean, the concept that the mitochondria are actually bacteria which have gone into the cell. So they are different sort of organism which is living inside our each cell. So how did the bacterial DNA get into our nuclear DNA? I mean, so why is it not completely separate?
Yeah, I'm not sure if I have the answer to that question. I will have to do some reading around that.
Okay.
That happened a long time ago.
Yes, long time ago. But still, I mean, now they are blaming the mitochondrial DNA for excessive immune response. So when you have some, if there is some tissue damage, then the mitochondrial DNA gets exposed, and then that causes a lot of inflammation. So they are blaming it in all sorts of these inflammatory responses also. So the mitochondrial DNA is becoming very important.
Okay, so I'll just quickly run through the questions. I think there's only one more which I thought really needed to be answered because that's really very specific. Notating hyperlipidemia in pedigree. What is the role of inserting a small square in the corners of a pedigree square or circle? Yeah, I think I've also seen that once. Can you
see? So if there are many disorders, so sometimes we put like a small square that you could actually make your own key. So you could make a small square, say it says hypertension or hyperlipidemia, and the other circle in the other corner. So each corner could be one disorder. Does that make sense? So if it's a left corner, it means hyperlipidemia. If it's the right corner, it could mean diabetes or things like that. So when there's so many, I don't think there's a rule for which corner it can be. You can make your own key as long as the key and the pedigree match. It works.
So basically, I mean, this is the language of the genetic clinic.
Yeah. All of us hopefully they will simplify it in their notes that you can read it. I don't think neurologists are expected to read pedigrees.
Okay, a little difference between epigenetics and single genetics. I mean,
Mendelian. Yeah, so epigenetics exactly is an example where when gene is made into proteins, so the example of epigenetic disorders is methylation defect disorders like Prader-Willi and Angelman syndrome, where there is a methylation defect in how the gene is expressed. So it's not the mutation in the gene, but how the gene was processed. So a step after that. So single gene disorders, say there's a sequencing error. So you're reading the NF gene ACTG and T is missing or C is missing, that is a single gene disorder. But if the histone code is a separate code, if there's more methylation, less methylation, so when there's a methylation defect, those disorders are considered epigenetic disorders. And the classic example would be, in my mind, Prader-Willi and Angelman syndrome for our purposes.
Not so big in neurology as compared to oncology, for instance, I guess.
Correct.
Isn't that
what controls the epigenetics thing? I mean, so the gene expression is controlled even later after the gene is formed by the epigenetics. So what controls that?
Yeah, there are many factors. So I think one big thing we can all know that controls is something called microRNA. They're very new fancy term in DNA language. So if you want to read about microRNAs, you can learn a lot about how gene is regulated and controlled. So I would say that as a good example.
I mean, isn't that epigenetics is to do with turning off and on genes at various times and
you got it.
regions?
You got it. Yeah. So different genes can express less or more at different times in a life cycle, or in different tissue specific. So exactly that. Yeah. But I think those are more, as you maybe said, maybe in more cancer or acquired. While when we're talking about inherited or Mendelian disorders, then there are very few examples for those.
Okay. Now I appreciate that it's really late for you on a Saturday evening. The last, I think I'm going to ask this. Would you want to explain linkage analysis in short and kind of we stop at that?
Yeah, so linkage analysis is a technology or technique that is used for gene discoveries. So the simplistic way of thinking about it, you're trying to find an unidentified or a new gene, but you know the genes that are before or after, so they're kind of linked together. So that's really what linkage analysis is. It's used mostly for gene discoveries because you're suspicious of a specific locus, you make probes for around, so they're kind of linked together and you try to study them in inheritance. So that's where its application is. In our clinical field, I think we're way beyond it. We can sequence the genome now, so we really don't need linkage analysis. But for gene discoveries, that's what we use, or it was used.
I have not understood incomplete penetrance versus incomplete expression. Which diseases have incomplete penetrance?
So a lot of adult onset neurodegenerative disorder genes, for example, dementia genes, so like presenile 1, 2, frontotemporal dementia genes, those are classic examples where you could have a gene mutation, but you may not have the disease. So they're incompletely penetrant. But neurofibromatosis type 1, tuberous sclerosis, all these neurocutaneous disorder genes are completely penetrant, though their penetrance is age dependent. So a child may not have all the manifestations of NF. They may only have cafe au lait or freckling, but as they get older, they get more neurofibroma. So it's age dependent penetrance, but they're completely penetrant. But that's variable expressivity where you have different features, or mild versus severe.
Okay.
Done.
Okay, thank you.
That was lovely. I mean,
that was very nice.
So, okay, I'm glad you enjoyed it. Okay, yes. Thank you. I'll see you next Sunday.
I think to explain something nicely requires knowing it yourself very well, and you really told us how well you understand it. When you explain it so simply, it makes us think that we also know genetics.
Okay, I'm glad. Yeah, I'm a clinical geneticist, so I may not understand the technology as well, but yes, I know what I do in the clinic. So.
Thank you.
Thank you so much.
Look forward to next Sunday. Thank you.
Yeah.
Bye.
Thank you. Bye.
Ashish, we'll have to ask Ashish. He had some problem.
Okay, Sudhir, there are a couple of other things. अभी बात करें. Subhash भी है. Subhash जागा हुआ है.
नहीं, अभी तक है ना, चल रहा है. The thing is
broadcast बंद करना.
No, we have Ashishka's quiz.
Oh, I forgot. Sorry, poor Ashish. Every time we.
Yes, but he has some problem with the thing. So let me. Ashish, are you there?
Oh God.
So he was in the attendees. I had moved him to the panelists. Now I'll move him again 1 minute.
Yeah, but he had some issue.
Meaning?
Something with the quiz. He did the Slido in his own account. He didn't use the Fine account. So some problem.
Not working.
Yeah, may not work. His quiz should be renamed JINX.
Every time he presents something or the other.
I know.
Ashish, there he is.
Ashish, instead of QUIZ, we shall rename it JINX.
Hi, sir.
Bolo. Are you ready?
problems problems hai abhi. If you can give me 5 minutes, I can sort it out. Otherwise, I think we can.
No, if it is,
we'll have to.
Maybe we can. If don't spoil it.
Is it okay if I take 5 minutes? Sorry.
If you can do it in 5 minutes, no problem. We can.
Yeah. So maybe if you can go ahead with some other discussion for 5 minutes.
Yeah. So I think since there are so many attendees, it will be nice if all of you can tell us honestly what you think about this, what is going on. If anybody wants to tell us about how this whole experience is working out. One question that I have in general for everybody is, how do you think this will work out, say, a year down the line when physical conferences start? Anybody? You can type it in. You can type it in the Q&A.
So should we allow the raise hand?
Yeah, raise hands and then.
No, Roop, I'm starting a Slido. Let people write in that whatever they want to.
Oh, like nice.
Just join at H075 and add your whatever comments, questions. Let's see.
Yeah, let's do a.
So join Slido.
Yeah, I'm doing it. H075. What is that? Yeah. Here. At least I'm on board.
Yeah. So we'll just have word cloud.
Yeah.
Can you write something? Just try.
I would type your question.
Yeah, would work very well. Yeah. So people are writing their things.
Okay. So, okay.
Any suggestions?
So word cloud on, say, this same. Are you putting word cloud on?
Yeah, I'm putting word cloud. 1 minute.
Yeah. What do you think about this? Just give us one word. Say, going on from next August onwards, August 2021. How will this work?
Okay, so.
How do you think this will work?
Are you seeing it in your Slido? The question.
Yeah. How do you think this will work? Enter a word. I think.
Wait, this has not come as a word cloud. 1 minute. Yeah, it's coming.
I've said well. I'm not. Who said fantastic? That must be you, Sudhir.
No, so fantastic is the big word. Is if more people say fantastic, the fantastic word will become bigger.
Yeah.
So 2 hours is less people are saying. Some people don't want more than 2 hours. I'm going to ask that next question.
नहीं चलने देना वो. The people are.
नहीं ये चल रहा है. But next question, how many hours do they want? What topics do they want? Let's ask them now.
Okay, so nobody is unenthusiastic like me. I said just well.
How many hours? That's the next one.
Where is it gone? Yeah, go on. So, how many hours? I'm putting down 2. Did you put anything, Sudhir?
No, I'm not. I'm writing.
I've written 2. Somebody said maximum 2 hours. Yeah, it's clustering around 2. Lots of people hit 2. Just send the number because then that number will become, but 1.5.
So max 2. I think we'll go to the next.
Yeah, 2 hours is fine. So everybody says 2 hours.
How many days a week?
No, but we are doing this only Sunday and Saturday
so
evening.
I'm asking.
Fluctuates.
So let's see. Most people are saying once Sunday. Yeah. So again, we got once.
What about the Saturday evening? Yesterday we did Saturday evening.
We might have occasional Saturday evening.
Okay. So one Sunday every week. That means that is every Sunday. Every Saturday also? Or how many Saturdays in a month? No. Ask how many Saturdays.
I'm asking.
How many? In a month. I'm saying 2.
Sure. पहला वो ये आ रहा है. That's important thing is what topics. ये देखो. What do they want? No, wait. 1 minute. I'm just resetting this. People are mixing up the question.
Yeah.
So for this, what do you wish for? Is only talk about what topics or what sort of thing activity you want. Not
no,
day.
So then no, you'll have to give them a choice, Sudhir. I mean,
no choice. Let them say what they want. Practical, EMG, movement disorders. Whatever becomes bigger will happen. Clinical neurology, practical. A lot of guys want EMG, huh?
Cognitive.
No one for neurotology. I think I gave too much.
मेरा न्यूरोपैलिएटिव भी किसी को नहीं मांगता है. Yeah, ठीक है.
Okay.
ठीक है.
So what we don't know already, can you tell what? Okay. So I think we get an idea. People want practical clinical neurology. A little more of EMG and electrophysiology is needed. Nobody wants EEG, but I think
there is one small EEG. It just popped
but mainly EMG ज़्यादा लगता है.
EMG was more, yeah.
Okay, then we go here.
How many Saturdays in a month?
How many Saturdays in a month?
You have to explain to them that the Saturdays are important for
international speakers. We have to have on the Saturday
because Dr. Dhamija was very kind to stay awake at past midnight on a Saturday night for her.
Yeah,
it's not fair to. Not everybody is going to do that for us.
So I think alternate Saturdays. See, MDSI is there on Saturdays. I know.
Yeah, I agree. But
alternate we may have to do.
Yeah.
Because we can't get Saturday, we can't have many international, especially US, East Coast and European speakers. We have to have on Saturday night.
Yeah, because think of, say, somebody from even the UK. I mean, at 10 in the morning, they're going to be getting up at 5 to give us a lecture. It's not possible. Yeah, are you enjoying Slido? Yeah, at least, this part of Slido really works well. Yes. What did you send?
I spelled it wrong on the fly, but okay.
Are you enjoying? Yeah, that's okay. I do enjoy it. I think it's very good for responses. It's easily I can't see anything that goes now. Of course, fast. You're too fast for us. But otherwise, if somebody goes a little slowly, I mean, you can really do a hell of a lot of interaction. It's like.
Yeah. और क्या पूछने का है?
आशीष तैयार है क्या? पूछो उसको अभी. Ashish, are you ready?
Yes, sir. I'm ready. I'm ready.
Done. Okay.
The only thing is I had to do all slides again. So I hope they run well.
Okay, so why don't we use
last one.
How is Corona in your city?
Mumbai is number 1.
Somebody is rocking.
Yeah.
Okay, chalo, Ashish.
Yes,
so will we
I'll do slideshare.
Yeah.
We'll use the same Slido.
He'll do.
No, I'm using that mine this thing. I hope it works. Last time some students were not able to see. I hope it works well now.
We close this one and then go on. Okay.
Yeah. Chalo, Ashish, start.
Yeah.
Yeah, is it visible?
Yes.
Okay, so I think without wasting further time, we'll start the quiz.
Yeah.
Thank you, Fine Forum, for this opportunity, and hope we complete the quiz today. Okay. The code is 19720 for the quiz. So please go to slido.com or open your Slido app. In that, you have to put that code, that is 19720, today's date. And in next, you have to go to polls. Then you will have to enter your name. If you want to remain anonymous, you can put anon or XYZ, whatever. And then we are ready to go. Shall I proceed?
Yes, go ahead. Go ahead.
Yeah. So the first question, basic one. The word ataxia means without stance, without axis, without order, without tone, or without taxi, because there is no taxi available during lockdown. Oh God, the Slido has fooled us. It didn't show the question, sir. Hello?
Don't stress yourself. I think you can do it again next time. It's all right.
Yeah, yeah. I think the Slido is not.
You have to have your own this. So, okay. Roop, you want to ask anything?
Sorry?
No, Roop, you want to ask anything more? Otherwise, Ashish, have it later. It's okay.
Blunder. Thunder blunder.
So, any questions or anything else?
Speak to Ashish. Let me speak to Ashish. I think, Ashish, you know,
yes, sir?
It's okay. Let's get it done once it is done properly, because we all need it. So,
sir, I took so much effort, but some are the other issues.
Next week, it's okay.
Fair enough.
We have it next week. Relax.
You are our favorite guinea pig. Don't worry.
Yeah. Okay. Bye, everybody. Thank you. And we look forward to Saturday, Sunday next. And take care. Be safe. Bye. Any ideas, you can email us or write in the next slide. I'll make a little more detailed poll also, which we can do offline. We don't have to do it instantly, and we'll just try to gauge what are the new topics that you want. Okay, thank you and have a nice weekend. Roop, you want to say anything? Okay, let's leave.